Okay, go ahead.
All right, so good morning, good afternoon, good evening, everyone. My name is Jambin Juguna, and I work with FHI 360. Today, I'd like to welcome you to today's ICASA satellite session. I'm giving you a small introduction on the pathway to PrEP, how we expanded access to HIV prevention options for adolescent girls and young women in Kenya through integration with family planning services. Next slide. So adolescent girls and young women in Kenya have quite a high unmet need of family planning. At the same time, we have a high percentage of pregnancy among young women, particularly those that are between 15 and 19. When you think about HIV, a good proportion of new infections occur among adolescents. That is about 1/3 of all new infections. And when we specifically consider adolescent girls and young women, about 1/4 of all new HIV infections occur among those 15 to 24 years old. Next slide. So services, integration of sexual and reproductive health services and HIV integration of HIV and sexual reproductive services really helps assure that women living with HIV and at high risk of HIV, including adolescent girls, young women, key population members, and pregnant women, can access information and services that empower them to fulfill not just their HIV needs, but in totality, their sexual and reproductive needs, goals, and rights. Next slide. So when we consider sexual and reproductive health services and HIV services, there's a nexus for the two merge and look at the woman as an entirety, not have among these services that would assure the woman who has both needs, both their sexual reproductive health needs and HIV services needs are met at one point. And having where everything that is pertaining to the woman's sexual and reproductive health services is provided under one roof. Next slide. Next slide, please. So when we look at, all right, so what does the evidence say about integrating sexual reproductive? Shown that this is very desirable for clients. There's increased service uptake, there's decreased stigma, improved quality of care, and there's actually more efficient use of limited resources. And at the same time, it does promote better understanding and protection of rights of young women. Next slide. So when we look at the studies that have been shown, there was the ECHO study that was a catalyst for PrEP-FP integration. And one quote from a civil society working group on working on this showed that ECHO was a wake-up call to put HIV prevention on site at every family planning clinic and include PrEP and female condoms in the provision of these services. Next slide. When we look at WHO guidance, there's a lot that has happened there. There's a guidance on contraceptive eligibility for women at high risk of HIV. And one of the key things that is there is that there's a recommendation that in settings with HIV prevalence, with high HIV prevalence, HIV testing and prevention, including PrEP, should be included in family planning services. So there is guidelines that guide this integration. Next slide. So, which brings us to the question, what does it take to integrate PrEP into FP services? So this session that you have joined will explore progress, challenges, lessons learned from PrEP FP integration efforts in Kenya and offer practical recommendations for taking PrEP and family planning integration forward in both Kenya and within the region. And we'd like you to participate with us and join us in discussing fully how this happens. Next slide. So as an agenda, that is what we have planned for today. So after me, I will introduce the next session, which is for PrEP FP integration. We'll talk a little bit about the results of the PrEP Family Planning Integration Quality Improvement Initiative that we did here in Kenya. We'll have a moderated discussion with family planning providers from Nairobi County, where this integration happened. And finally, we'll look at future directions for PrEP-FP integration, research, and programming. So we hope at the end of this, we'll have a clear picture of how PrEP and family planning was integrated in Kenya and a way forward for moving this in the region. Thank you very much. At this juncture, I'd like to welcome Ruth Kamau, the PrEP Program Officer for the National AIDS and STI Control Program, to tell us more about integration within the country. Welcome, Ruth.
Thank you, Jambi. I'll be taking you through the journey of integration by National NASCOP and the Division of Reproductive Health. My name is Ruth Kamau, working with NASCOP as a program officer supporting PrEP services. Next. The Kenya integrations journey. HIV and SRH integration has long been a priority for the Ministry of Health Kenya, as reflected with the availability of several policy documents. But despite prioritization, service integration has not been fully realized. Sorry, maybe start over. Sorry.
No, that's okay.
Okay.
Go for it.
Kenya's integration journey. HIV priority for the Kenyan Ministry of Health, as reflected in several policy documents. Despite prioritization, service integration has not been fully realized. Next. And this is the journey of integration work in Kenya, which began in October 2019. Between October 2019 and January 2020, we conducted a HIV SRH assessment in facilities. In February 2020, we had dissemination meetings. July 2020, we established a national HIV SRH integration subcommittee. In September 2020, we began policy review and development of draft circular. In September 2020, we had regional consultative meeting with the counties. And in January to March 2021, we developed SRH and HIV prevention operational manual. In August 2021, we piloted SRH and PrEP integration in 5 counties. Next. Objectives of the integration assessment. One was to gain better understanding of the potential for integration for PrEP and other biomedical prevention and family planning products at facilities serving adolescent girls and young women as one approach to improving access to uptake of these methods by AGYW. And 2 was identify characteristics and the training needs of integration champions for engagement at different levels of the healthcare system and at various points of entry at health facilities to inform policies and training approaches. Next. The key findings of the integration assessment. 1, most facilities offer both PrEP and HIV services, including PrEP. However, the level of integration and youth friendliness vary by facility and type and amount of external support by implementing partners. There is a strong need to capacitate providers, particularly train and supervise SP providers on HIV prevention and PrEP service delivery. There is a need for up-to-date direct operational guidance on integration from the Ministry of Health at national level and enhanced coordination at county level. Separate HIV and FP monitoring and evaluation tools hinder integration at facility level. There is a potential to advance integration through innovations in private sector, including private facilities and pharmacies. AGYW wants choice, access, respect, and privacy. Fear of stigma from community and healthcare worker attitudes are major barriers to accessing services. Next. Key recommendations from the assessment. Update existing SRH HIV integration policies to address inclusion of PrEP within FP services and create operational guidance on how to do so. Strengthen and expand youth-friendly services service delivery to promote access to comprehensive SRH and HIV prevention services for AGYW. Increase PrEP awareness and demand creation among providers and communities. Build provider capacity to deliver PrEP and youth-friendly HIV SRH services for AGYW, establish an integration committee at national level under the co-leadership of NASCOP and Department of Family Health. This was formed and has had 2 teams. 1, policy review, and 2, integration policy circular. The policy circular, training curriculum, and IEC materials were developed. Partial funding secured for 5 counties to pilot integration. Next. The next step, pilot PrEP FP integration in 5 counties, which are Marsabit, Uasin Gishu, Kakamega, Makueni, and Nyeri, before rapidly scaling up to the rest of the country. Use lessons from choice-supported PrEP FP integration quality improvement initiative led by LVCT and FHI 360 in Nairobi to inform national pilot. Conduct trainings for provider on PrEP FP integration and support implementation in 5 counties. Demand creation, conduct outreach within communities for integrated services, including printing of IEC materials with support from implementing partners. Make PrEP FP integration a part of quality improvement in facilities. Next, thank you.
Thank you very much, Ruth, and for giving us an overview of what the government has been doing as a background for that. At this point in time, I'd like to welcome Patricia Jekonaya from LVCT Health to tell us about the results and lessons learned in a quality improvement initiative integrating PrEP and FP in Nairobi County. Welcome, Patricia.
Thank you very much. And my name is Patricia, as you've heard. Good morning, good afternoon, good evening from wherever you are. So today I will share the results and lessons learned from a project known as Choice that supported the PrEP FP integration, quality improvement approach in Nairobi County. So I will be sharing with us the processes, the results that came out of this work. Next. This is the outline. We will look at the introduction, the methods, results, challenges, and the lessons learned. So the goal of this particular project was to increase access to uptake of oral PrEP amongst adolescent girls and young women by integrating oral PrEP into family planning services. Next. So the project was set out to achieve 3 main objectives. One was to engage the different stakeholders from the county level, sub-county facility level, and also at community level by working with champions to be able to integrate PrEP into FP services. The second was to identify the tools, the practices, and facility level changes that support the effective delivery of integrated PrEP and FP services to AGYWs. And lastly, to disseminate the results of the Quality Improvement Collaborative and to promote utilization of effective PrEP FP integration practices and tools to other policymakers, program implementers, and providers in Kenya and the region. Next. So we utilized this approach to enable us constantly identify bottlenecks, identify the key areas that required improvement to make PrEP FP integration work. So the process included identifying what the main problem was, and we also utilized different root cause analysis methodologies to be able to identify and analyze the problem, and lastly, develop a methodology or an approach to be able to address the problem. And we utilize the Do, Study, Act, the Plan, Do, Study, Act approach to be able to implement and test the strategies. Next. So part of the process that we had to go through to be able to respond to the objectives of the project, we established leadership for the Quality Improvement Collaborative to include the county health managers and sub-county health managers, enrolled the participating facilities, conducted entry meetings with those facilities, and we further engaged the FP providers and AGYWs and conducted workshops on quality improvement. Then we went ahead to develop tools such as the job aids, the monitoring and evaluation, because we had different tools for documenting the data. So we needed a tool that would be able to integrate all this data. And then we conducted the trainings for the providers, and the teams that were being trained included the providers who offer PrEP in the facilities. It included the HTS counselors. It also included the FP providers and the quality improvement leads within those facilities. And because this work happened during the COVID-19 pandemic, we delivered most of it virtually and also managed to do a hybrid where part of it was also done within the facilities. And we had to do like a two-part training, which we also learned a lot of lessons. We did the first one in December and had a follow-on in March. And what we realized with the second part of it is that we had to actually do a refresher. And then we developed a supervision schedule and were able to conduct the supervisions and conducted also quality improvement learning forums where the facilities were able to learn from one another and look at the strategies that were working within those facilities and also replicate them across the 3 facilities. Next. So the facilities that participated in this were taken from 3 sub-counties, and these facilities were selected by the county, given the targets they had for PrEP, and also that they were working with adolescent girls and young women. Next. The 3 facilities, through their engagement, all agreed to pursue an internal bidirectional referral-based supermarket model of integration. And the main reason why these facilities settled for that approach that is circled by the red color is that, one, the provider's capacity and specialization was a major issue that needed to be addressed, because you're either an FP provider or you're working within the comprehensive care clinics where people are picking the oral PrEP, or you're an HTS provider. And the second reason was that most of the FP providers had not been trained on PrEP delivery. And lastly, that PrEP was also being offered in the comprehensive care clinic. That is where the HIV positive persons pick their ARVs. Next. And we needed to develop or adapt some of the materials to help in demand creation and also to support the providers in ensuring that PrEP FP integration was working. So we developed standard operating procedures, developed training materials with the national team and also the county teams, counseling job aids, screening tools, monitoring and evaluation documents, and also demand creation materials. Next. So we had key indicators that we used to help us track whether PrEP FP integration was actually working. So one of the indicator one was percentage of FP clients screened using the risk assessment tool for indications for referral for further PrEP assessment at the facility. Indicator 2 is the percentage of clients, FP clients, found to have indications for referral for further PrEP assessment at the health facility upon completion of the RAST. Indicator 3, percentage of FP clients found to have indications for referral for further PrEP assessment at the facility upon completion of the RAST referred for PrEP. Indicator number 4 are the clients who are eligible for PrEP, and indicator number 5 are the ones who are eligible for PrEP and are actually initiated on PrEP. Next. So these are some of the findings, or rather the results from the work that we put into these 3 facilities. And just to take note that we continued to use the facility registers and referral forms to help us fill in the numbers across the 5 indicators. And also all the 3 facilities had 0 clients, 0 FP clients who had been initiated on PrEP when this particular project started. So one of the facilities, Mokuru, were able to see 2,314 clients and were able to rust 86%. The expectation was that all facilities would actually rust 100% of the clients and be able to document that. And as the cascade continues, we see some drops in numbers where we had about 5% of those eligible for referral for PrEP. And out of the 102 that had been referred, we had 96% of them reaching the referral point. And those who were eligible were 32%, and those finally initiated was 71%. Lunga Lunga managed to do 1,270 and finally initiated 29. And Kangemi saw 2,214 and managed to initiate 5. Next. We can move to the next slide. I think that has already been mentioned. In terms of just understanding the results, the overall uptake of oral PrEP was low. We managed to get 56 FP clients initiated on PrEP during the 6-month period. And we observed a wide range of variations in the performance on key indicators across the 3 facilities. And also as part of the routine quality improvement coaching and quality improvement meetings and supervision visits, we managed to document the reasons for declining services amongst the FP clients who are being initiated on PrEP, and other reasons for why we see the drop-offs in numbers that included strikes and other shortages within the facilities. The project was not designed to assess PrEP continuation across the period. Next. So some of the key challenges that we just want to highlight within the context where the integration was happening. COVID-19 came in just when the project was starting. Healthcare workers' strike also came in the process, and we also had shortages of HIV test kits. Within the facilities, the challenges that were documented included reluctance by some providers to integrate services, citing high workload, negative attitudes among the FP and HTS providers towards oral PrEP affected uptake. And here we are saying that it's important to be able to address provider values to help them be able to offer responsive services. High rates of transfers or attrition amongst those who had been trained, lack of cohesion amongst the providers, inconsistency in documentation and administration of RUST, and high expectation from providers to have additional motivation. And from the client side, we had a number of them declining to be initiated on the same day or had to consult their partners before they could get PrEP, and also due to long waiting hours. Next. Some key lessons learned. We had routine engagement and also co-implementation of FP and HIV stakeholders at national, county, and sub-county level. So just ensuring that there is collaboration and working together. Cohesion amongst the FP, HTS, and PrEP providers is key. More than one provider in each service delivery point should be equipped to ensure that when one goes on leave or there's transition, the work does not stop. Next. Ongoing trainings on adolescent-friendly services also helped in terms of addressing the provider biases, and routine coaching and supervision is critical to continue building the capacity of the providers and to ensure that there is continued leadership from the sub-county, from the county, and also the facility. Next. Regular data reviews and supervision needs to be a continuous process. New procedures and tools may be needed for routine monitoring, and also for supermarket model, the referral process may need to be strengthened. Potential solutions included to escort the clients to the service delivery point, and this can be done by using the peer ambassadors who can work with the clients. Next. Greater investment is needed in awareness raising, and also it's important to address intimate partner violence, to be able to optimize impact of integrating PrEP FP services. You should be able to have efforts to address the structural barriers. Quality improvement methodologies are a promising approach. And so, as mentioned by NASCOP, that this is something that we will be including in the national rollouts. Next. So thank you very much. Hope you can also have time to read into detail some of the parts that we had to skip. Thank you very much. Back to you, Dr. Njambi.
Thank you very much, Patricia. And thank you for highlighting all the work that has gone on within the County of Nairobi when it comes to PrEP and family planning integration. It has been quite interesting to look through those slides. At this moment in time, I'd like to welcome us to listen in to a panel discussion that will be moderated by Dr. Caroline Ngunu, the HIV prevention lead at the Nairobi County. And she will be leading a panel of participants from the 3 facilities that Patricia has just been introducing to us through the previous presentation. And we can learn from them how this has been going on. Dr. Ngunu, welcome, and feel free to introduce the panelists. Thank you.
Jambi, for that. My name is Dr. Carol Ngunu. I am the Deputy Director for Preventive and Promotive Health Services, and have been the technical lead in the past of the HIV program when we were starting PrEP FP integration. With me today, we have Anne Maru. Anne Maru is the facility in charge at Lunga Lunga Health Center. She's in charge of the FP PrEP integration site. Then we have also on the call, we have Kevin Okoth. Kevin Okoth is a clinician in the comprehensive care clinic at Mukuru Health Center, which is a health center that is deep within the Mukuru slums towards the east of Nairobi. Also joining us today, we have Jane Washira. She is a family planning PMTCT provider at the Kangemi Health Center. So I would like to welcome you all to this panel session and welcome our panelists. So I'm going to start off the panel discussion by asking a question to you, Anne Maru. And so in your experience, what are the benefits that you have seen in your facility of integrating PrEP and family services, family planning services for the adolescent girls and young women at Lunga Lunga Health Center? Anne?
Thank you so much, Dr. Caroline, for that question. One of the benefits that we've learned at Lunga Lunga Health Center is that it has helped us to reach out to more adolescent girls and young women into the family planning and PrEP FP services. Then generally it was geared towards reducing the unplanned pregnancies and acquisition of HIV. Another benefit is that the initiative has offered us an immense platform to reach to the target populations with sufficient health education and information. PrEP FP integration in Lunga Lunga. Thank you.
Yeah, thank you very much, Anne, for that. I'd like to ask a similar question. What is your experience on this, Kevin, in Mukuru Health Center?
For Mukuru Health Center, what we've really noticed was risk awareness. This integration has really brought forth the information about risk of HIV for AGYWs on family planning, especially that age cohort that we are targeting between 15 years to 24 years. So the awareness of risk of contracting HIV due to their sexual behaviors was really wanting. So with the integration of these two services, it has really created, and it has been an eye-opener for this age group, for them to know that they're at risk of contracting HIV and therefore need to prevent themselves from contracting HIV. This has also helped us for them to know that they are at risk, and also help in reducing the disease burden of HIV through prevention. And it has also improved our quality of care, since they are getting both services integrated. It's really an efficient way of providing both services at the same time. And it has, the ones that have taken it up really have good response towards both services being integrated, as it's sort of you're hitting two birds with a single stone.
Thank you very much, Kevin, and Anne, for those responses. Jane, I know you've been doing a good job on integration at Kangemi, and however, I'm sure you've undergone some challenges. What has been the most challenging aspect of integrating PrEP and family planning services for you at Kangemi Health Center? Please share with us your experience.
Yeah, thank you, Ms. Bruno. So at Kangemi Health Center, we've experienced some of the challenges, especially in terms of the issue of sensitization. People come to the facility when they are not fully aware, so they make impromptu, they make decisions that are fast. By the time they are getting to preparation, and then they get to know that it is not something they will take once, it's something they will take every day. So they stop at that. So one of the challenge is the issue of sensitization. We learned that we need to sensitization of PrEP FP integration needs to be really done. And also the challenge of staffing, the shortage when we have high numbers of staff, and we have high number of patients who need to be rested or to be screened, but we have a shortage in staffing. So really, it was a bit of a challenge. The other challenge is the issue of the structure, of which maybe something that may need to be looked at in the other facilities. The structural issue in that you have to refer from one point to another, escorting one client to another, from one station to another. So given it's not in the same room, it was a bit of a challenge. Yeah, thank you.
Thank you, Jane, for being so honest and sharing your experience, because I'm sure some of these challenges you have been able to come up with recommendations, and just hearing about some of the things that perhaps could be done better is important as a learning point for other facilities. Anne, you've talked about the benefits that you experienced at Lunga Lunga for when you integrated these services. I'm just interested to know, maybe you can share with us, what kind of feedback, either good or bad feedback, have you received from these adolescent clients who came to you for their family planning services and left both with a contraceptive method and oral PrEP for HIV prevention? What are some of the feedback that they've given to you?
Thank you. The feedback that we got from the AGYWs who came for subsequent visits for the PrEP FP services after the initial integration is that they breathed a sigh of relief like it was a new life, because they had since realized the risks they were at when they are engaging in sexual activities and they are not preventing themselves from contracting HIV. So it was really good for them, for their lives. That's the feedback that we got from the AGYWs.
Thank you. And Jane, any feedback from your side? I know you've talked about challenges, but any feedback that made it maybe worthwhile to give these services from your side at Kangemi?
Yeah, sure. So the one feedback that is almost everyone really left saying was if there was a better, not really, okay, if there was a better way of preventing them, like maybe a one pill for the month or an injection, like a better formation, they preferred a single thing for a long period of time rather than the daily pill for the month. Yeah, but either way, it is a relief, and most of them, apart from that, we never had a good uptake, but they had their thoughts, and those who picked, they said it was a good thing. Maybe I can just mention something from the first question that you asked about the benefits. In the facility, we have picked it is a nice platform that we were able to screen the GBV, IPV, and we've recorded some and we've reported some. So that was also a benefit among the others that have been mentioned by the group. Thank you.
Thank you very much, Jane, for that. So Kevin, you told us that the integration was a success for the adolescent girls and young women. I'm just wondering, and at Mukuru Health Center, do you offer adolescent-friendly services, sexual reproductive health services, and what can providers do, in your opinion, to improve quality of care for these adolescent girls and young women?
For provision of youth-friendly services, yes, our facility is one of the facilities that do provide youth-friendly services. Now, when it comes to other facilities, advice that I could give to other healthcare providers is just keep an open mind with the adolescents and the young age that we really serve. You really need to have an open mind, be ready to listen, always be ready to tailor make solutions as per everybody's needs, because different youths, as much as they might be in the same age group, their needs are different. So you have to be alive to the fact that these are population group that is growing. They are experimenting on things. So you really need to keep an open mind and know that they are really, really a unique group. You need to be sensitive to their needs. You really need to keep an open mind. Don't be judgmental. Always be ready to answer their questions. Always be ready to serve them as per their needs. Always be innovative when you're around this age group, because it's a really tricky age group to handle if you don't keep an open mind. Yeah.
Thank you very much, Kevin. Anne, any insights on the same? What can providers do to improve quality of care for adolescent girls and young women? Yes,
Yes, I can. Yes, I'm saying that to my fellow healthcare providers, especially those who are working in facilities that are providing the youth-friendly or responsive services, they need to change their attitude. You need to put aside our personal beliefs so that we can be able to work with the young adolescent women. And because these people are so much into the internet, so they'll come with so much information. but you need to be very well informed so that you can be able to explain to them and they can be able to understand you so that they can take up the services. Thank you.
Thank you very much for that response. So I'm going to go on to my final question, and I'll ask all the panelists to give us, in a minute or so, a piece of advice that you would offer other providers who are being newly tasked with integrating HIV prevention and family planning services. What advice would you give those providers? We shall start with you, Jane. What advice would you give a provider who is tasked to start up these integration services?
Thank you. So for me, I would say that I would advise every colleague that let us be responsive to this age group. Let us change our attitudes. Let's be professional and be conscious about our cultures and values so that we just do what we are required to do so as to serve the community and specifically for this age group. And the very key thing is to create more awareness and to make them accept it in a better way without adding things that will change their belief or their things that will change their attitude towards PrEP-FP. Yeah, so it's more of change of attitude and being conscious of our own values as we serve. Thank you.
Thank you very much, Jane. Anne, what will be your piece of advice?
I would advise the healthcare providers who will take up the PrEP-FP integration services to the adolescent and young women to avoid stigmatization and discriminating. You should be ready to stand in the gap of knowledge to these young girls, because most of them, they'll decline to the service because of lack of enough knowledge for them to make a decision. So be ready to stand in their gap and administer the services as required appropriately. Thank you.
Thank you very much, Anne. Kevin, what would your advice be?
My advice would be keep an open mind. These are very unique age group that we are dealing with. Always be ready to innovate, be ready to come up with new ideas. Never shy away from trying new things. Be ready to try new things, a way of approaching them, a way of convincing them. These are new concepts to very many people. So be armed with a lot of information on PrEP and be ready to disperse that information to this age group. So always be ready to innovate, have your knowledge, have your understanding of the PrEP and family planning commodities and its myths and misconceptions. Have your facts right before approaching them, and then just keep an open mind and always be ready to innovate. That is the biggest thing.
Thank you very much, Kevin. And I can see on the chat box an addition from Jane that we must embrace teamwork. In my experience with the moderators, I mean the panelists in our discussion, the facilities have done extremely well in integrating PrEP and family planning, and we've been able to get missed opportunities, people who will be missed opportunities to get onto PrEP, and the hospital experience has been improved because it becomes a one-stop shop for our clients at these facilities. So I want to thank all the panelists for your time today, for being very honest and open about your experience integrating PrEP and family planning, and for the advice that you've given any provider out there who may want to also start this integration. Thank you very much, and I'll hand over back to the moderator, Kwaheri.
Thank you very much, Dr. Ngunu, and thank you very much, Jane, Anne, and Kevin, for your first-hand knowledge and sharing of knowledge of integration. I like what Anne said as a reaction by the young women who have taken the PrEP and as they come in for because they did not realize how much risk they were in, and they were now protecting themselves. And I love how we have all given information to provide an open mind, and being in a from the USAID office. She's a family planning and HIV advisor, to give us some closing remarks. Welcome, Jane.
Thank you, Jambi. And thank you, Dr. Carol, and really many, many thanks to Jane, Anne, and Kevin. You have provided us with such helpful insights regarding the delivery of integrated PrEP and family planning services in Kenya. Greetings to everyone. I'm grateful for the opportunity to provide a few closing remarks for today's ICASA session. I would like to first start by acknowledging that the attention being given to integrating PrEP and family planning services builds on over 2 decades of advocacy, programmatic efforts, and research aimed at strengthening the integration of HIV and sexual and reproductive health services more broadly. In recent years, we know from the ECHO trial and other vital research that HIV prevention and contraception are critical for adolescent girls and young women, or AGYW, who are at risk of HIV acquisition and unintended pregnancies. We also know that integrating these services is desirable to youth and can improve access, uptake, and continuation. But even more, the integration of PrEP and family planning can empower AGYW to fulfill their sexual and reproductive health needs, goals, and rights. Yet, we must acknowledge that such integration is not easy, and it is not possible without commitment from all levels of the health system. To that end, we must first ensure that the necessary plans and policies are in place to support the integration of PrEP and family planning. In many countries, there is a need for up-to-date direct operational guidance on PrEP and family planning integration from ministries of health. There is also a need in some countries to better engage local government officials, health providers, and community stakeholders, for without their involvement, integration is unlikely to succeed. We must also seek to strengthen the management and use of resources to provide the highest quality of care possible to AGYW and all other populations. As we all know, HIV programs are typically better funded than family planning programs, and government and donor funding for these programs is too often siloed. Thus, exploring new avenues for coordination across development partners, ministries of health, and subnational actors is essential to support the integration of PrEP and family planning. Integrated service delivery is complex, and it is multifaceted. Different models of integration are likely needed for different types of health facilities and communities, but we must double down and make it happen and continue to learn while doing. AGYW want choice, they want respect and privacy, but service provider attitudes coupled with stigma from the community remain major barriers to youth accessing services. Asking health workers to provide both HIV prevention and family planning services is no small task. Therefore, we must identify new and creative methods to capacitate providers and inspire them to succeed. There is also great potential to advance integration through innovations in private sector services and in community-based service delivery, particularly as PrEP becomes more demedicalized. As we move forward with PrEP and family planning integration, the client must remain front and center. For AGYW, that means helping them to feel empowered and increasing their agency to make autonomous decisions regarding their health. It also includes considering their needs for male partner engagement in decision-making and asking about and addressing the potential risk of intimate partner violence. The HIV prevention field is expanding rapidly, with new products on the near horizon and the potential for at least one multi-purpose prevention technology just a couple of years away. As new products, such as the PrEP ring and injectable PrEP, come to market, we have an exciting opportunity to advance informed choice for both HIV prevention and family planning through integration. Addressing PrEP and family planning integration now will facilitate the introduction of new HIV prevention products in the future. Focusing our efforts on achieving a win-win for both PrEP and family planning is key to ensuring increased use of both services and greater client satisfaction. Identifying efficient and feasible approaches to service provision and demand creation will also make the path to wider scale adoption of PrEP and family planning integration more likely. Going forward, our research and our programs must continue to embrace a client-centered, choice-based, and rights-based approach to integrated service delivery. And our work must continue to focus on introducing and scaling up a range of integration models for different combinations of services, all with the goal of achieving better HIV and family planning outcomes for adolescent girls and young women and other populations. In closing, I would like to thank all of our presenters for their contributions to today's session. I would also like to thank you, the participants, for joining us. I hope you will share what you have heard today and find ways to advocate for integration in your part of the world. Thank you. Asanteni sana.
Thank you very much, Jane. And I think we are now coming to the close of our session. I like those parting shots, are client-centered, choice-based, and rights-based solutions. And this is what we aim to do with PrEP and FP integration. And with that, we thank you for your time, and we hope, as Jane said, you'll be able to advocate for PrEP FP integration where you are. Goodbye.